Hey guys, welcome to case 5. So let's just hop right into it. We have a 32-year-old woman comes to the physician for 10 kilogram weight gain over the past 9 months. She also has irregular menstrual cycles, difficulty sleeping. Menses occur over irregular intervals. She has a 1.5-year hypertension treated with hydrochlorothiazide. BMI is 34, kind of high, right? A bunch of normal vitals and a blood pressure of 127/89. Still a little high considering she's being treated with hydrochlorothiazide. So examination shows acne of the face, hair on the chin and around the umbilicus. So we have some acne, some hair growth. She has a rounded shape of her face and her face is also reddened. There are several small bruises on both forearms. Which of the following is the most likely additional finding? So here's a picture of Our Lady that I found on Google. And let's go through each of the answer choices once you've had a chance to pick. So I'll give you a second right now. You can pause the video and then we'll go through them. So if you picked decreased bone mineral density, you are correct. So a lot of the hints in the question stem point you towards Cushing disease. We'll discuss why. And then one of the sequelae of Cushing's disease is decreased bone mineral density. So here we have our purple striae in Our Lady, our little moon faces. So when you see this, you should be looking for Cushing's. All right, so let's go through one of the answer choices was enlarged ovaries with multiple follicles. So this is really pointing to you towards a PCOS, right? And PCOS and Cushing's in a woman can be a little tricky to differentiate, but I'll essentially try to help you out in how to do it. So we have obesity in both, irregular menstrual cycles in both, hirsutism and acne in both, and hypertension in both. But if we're looking at the skin findings, Our Lady had bruising, remember? So bruising is from the collagen being less produced or destabilized from the high cortisol levels, and you'd also see the purple striae, right? This is more of a Cushing's picture instead of a PCOS picture. In PCOS, the major skin finding there would be the acanthosis nigricans from the insulin resistance. Now you could argue that you could potentially see acanthosis nigricans also in a Cushing's person because they also have insulin resistance. But if we're looking at the main skin differentiators, right, the bruisable skin really points you towards Cushing's. Then we have the disease onset. PCOS starts in adolescence, right? And Cushing's is more of in your 30s and 40s. So that's another big differentiator. Then the facial flushing and the moon faces also don't really make much sense for the PCOS patient. If they ever tell you someone has a rounded face, that's another, essentially a synonym for moon faces, and they're pointing you towards Cushing's. Next, we have discoloration of the corneal margin. So this is also called corneal arcus or arcus senilis. Basically cholesterol is depositing in the outer region of the iris, and we see this with lipid disorders, so hyperlipidemia conditions. And you could potentially argue, hey, this person has some obesity going on, their BMI is pretty high. Why isn't this going on? So this person, if they're really trying to point you towards a lipid disorder, they would give you something like a young person with a history of atherosclerotic events like an MI or stroke in their 30s or 20s or something like that. So that's one of the main giveaways for this kind of answer choice. And also we have irregular menstrual cycles, hirsutism, bruisable skin, moon faces, flushing, right? Those aren't really seen in patients with hyperlipidemia disorders on their own. Next, we have increased serum Epo, right? This one's also another one of the tough answer choices that we have to think a little bit about. So we could say, oh, we have a potentially obese woman, right? Obese people are more likely to have obstructive sleep apnea. Obstructive sleep apnea is associated with hypertension because of the vasoconstriction in the lungs, right? The lungs aren't getting as much oxygen. High CO2 causes vasoconstriction. This puts more pressure on the heart. Then we have hypertension. We can also have irregular menstrual cycles because of the adipose tissue in these obese people can affect estrogen levels, and estrogen levels can mess with menstruation. And we can even justify the flushing because, right, our obese person is more likely to have more EPO. Then the EPO causes polycythemia, facial flushing, all right? Then we have reasons why it's not this answer choice. So the bruisable skin, we really can't explain that with just OSA EPO, right? Moon faces, hirsutism, and acne. Hirsutism and acne, right? How are you going to justify those two? Those aren't just seen in run-of-the-mill obesity patients. So you have to look out for those. It's more of a hormonal picture, more pointing us towards Cushing's. Okay, next. Periorbital mixed edema. So here on the right I've included some pictures of periorbital mixed edema. You can see this with hypothyroidism, so low thyroid. What's pointing us, what kind of hints do they give us to kind of confuse us for this answer choice? So we have the weight gain, right? The irregular menstrual cycles. Remember, TRH is associated with prolactin, and prolactin can mess up your LH-FSH balance and then cause weird menstrual cycles. Then we have fatigue and hypertension. Again, hypertension is caused by the endothelium being more constricted in hypothyroid patients. The thyroid hormone actually works to help dilate the endothelium of your peripheral vasculature. So we have hypertension as a result of increased peripheral vascular resistance and hypothyroidism. Then we have things that don't really point us in this direction. So they didn't give us anything else like cold intolerance, they didn't give us constipation, dry skin, hair loss, right? And also we have things that we can't explain with hypothyroid, the facial flushing, the moon phases, the acne, and the hirsutism. Again, give us a more hormonal picture of Cushing's. Next, let's move on to decreased serum sodium. Okay, so decreased serum sodium, if you're looking at the kind of hypothalamic pituitary adrenal axis, would be seen with low mineralocorticoids. So if you have an Addison's disease picture where your adrenals aren't really working, low aldosterone, you aren't reabsorbing sodium, right? You could say, oh, you know, that would be a decreased serum sodium picture right there. And we could have in this person with Addison's disease, we would see weight loss, we would see lethargy, we would see intestinal complaints, hypotension. Remember, you aren't absorbing sodium, so your blood pressure would go down. Our person's blood pressure is up. You could see hyperpigmentation, again, because of the increased MSH. If your adrenals aren't working, you're trying to stimulate them with ACTH, and MSH is produced as a byproduct, which would pigment your skin. And then you would also see loss of axillary and pubic hair instead of more growth of hair, right? I don't really know why the hair changes occur with Addison's. So if anyone has an idea, you could leave it down in the comments. Then we have laboratory studies in this patient, which would show basically hypernatremia. So in our Cushing's patient, we would not have a low sodium picture. We are more likely to have a high sodium picture. Remember, cortisol can partially stimulate mineralocorticoid receptors, so it would tend to increase sodium reabsorption instead of decrease it. All right, so this is why decreased sodium is wrong. Then we have our correct answer, decreased bone mineral density. So why does that happen? So in high levels of cortisol, we have inhibited calcitriol synthesis. Now calcitriol are vitamin D3, right? So if you have low vitamin D3, you have low bone mineralization, so boom, there's your correct answer. Now you really have to watch out with the Cushing's patients because 50% of them are going to get osteoporosis because of this effect. And also you have to look out for pathological fractures and a vascular necrosis of the femoral head, which is associated with low bone mineral density. Right, so watch out for your bones in your Cushing's patients. Alright, so let's discuss a little bit about how you diagnose Cushing's and the steps to go through, because a lot of these topics I think are tested. So first thing we're going to look at is ACTH. If our ACTH is low, that tells you that the adrenals are producing more cortisol. So the high level of cortisol production from the adrenals is causing a negative feedback onto the pituitary, reducing the ACTH production, and you've essentially found where your cortisol is coming from. So really what we're looking for is how is this cortisol being produced in excess? We're looking for the mechanism. All right, so this is one of the ways of diagnosing it. First, you want to start out with the ACTH level. If it's low, you're good, you found the source. All right, then we have to look at if it's normal or elevated. So now we know that our ACTH is causing our excess production of cortisol because it's not low, right? In a high cortisol state, you would expect it to be low. If it's not low, that means we either have some tissue producing this ACTH that's like a potential cancer tissue or something like that, or we have the ACTH being produced from the pituitary. So the pituitary is either producing more ACTH, or we have this random cancer spot in the body producing this ACTH. Where is it coming from? if the pituitary is producing the excess ACTH. This is called Cushing's disease. So a little difference between Cushing's syndrome and disease. Syndrome just means high cortisol in the body. Disease means high cortisol as a result from the ACTH in the pituitary. Okay, so now let's play find the ACTH source. So we have here our Cushing's disease versus our ectopic ACTH production. For that, you want to do a high-dose dexamethasone suppression test. Okay, you give dexamethasone, which is essentially exogenous cortisol, into the system, and it should negatively feedback onto your pituitary and inhibit it, especially if it's a high dose. So the pituitary ACTH will be suppressed by this test. Right? If we have less than 50% of baseline, we found the suppression, and the ACTH is coming from the pituitary, aka Cushing's disease. If there is no suppression though, it's caused by ectopic ACTH production somewhere else in the body. So we have to go searching for it, right? You might want to do a CT scan for people like this. Then we have a Crh Stimulation Test. This is a little bit of an alternative. I haven't really seen this as the preferred choice. Usually it's the DEX test, but we'll see. So the Crh, if you look at our pituitary axis, it's produced by the hypothalamus, and it acts on the anterior pituitary, which causes ACTH production. Okay, so ACTH, if we give Crh, right, and ACTH and cortisol levels increase further, that means we're stimulating our pituitary, and bada boom, bada bing, it's making even more ACTH. That's a positive for Cushing's disease. Then if there's no increase in ACTH or cortisol levels, so our Crh is not really having an impact, that means it's not our pituitary that's hyperactive, it's somewhere else in our body. So here we're throwing basically stimulation towards our pituitary, seeing if it's going to react, and in our DEX test we're throwing inhibition towards it. Right? So both ways we're checking the pituitary. We're looking to see if we can catch Cushing's disease, or if we have to look somewhere else in the body for ectopic. And here I've included a little summary table for you with the hormone levels in each of the tests. So the low-dose DEX test is pretty useless because really it's just going to tell you if you're normal or not. So really low-dose DEX is only going to inhibit your cortisol production or your ACTH production, if your axis is normal. So low-dose DEX only does inhibition in normal people. For people with high cortisol, you're going to want to do high-dose DEX. And that's high-dose DEX and Crh testing are really your second level of testing and are going to lead you to your diagnosis of where the heck this cortisol is coming from. So in the first test, we've looked at the adrenals, which is our primary culprit with the ACTH test. And in the second test, we're examining the pituitary. And then once you've eliminated if the pituitary is causing it, then obviously you're looking for something ectopic. So those are our three levels. And here's our HPA axis just for your reference, which we discussed. Then treatment. So in treating Cushing's, you can have non-surgical or surgical options. And here we have the metyrapone 11 beta hydroxy inhibitor and the ketoconazole, which also inhibits cortisol production. We'll discuss these two more in our next video where we discuss low cortisol states, low adrenal states. So we'll look out for that video coming soon. And really the mainstay option is adrenalectomy. You really want to do non-surgical only if the person is a terrible surgical candidate, and you want to do adrenalectomy as your mainstay. So look out for one of the things they like to test. So let's say someone's had their adrenals removed. Now we have no negative feedback on our pituitary, right? No cortisol. So our pituitary is going to tend to go a little bit crazy. It's going to get a little big. So look for a mimicking sequelae of pituitary adenomas. So our pituitary might go a little crazy, might get a little big. You might start getting that bitemporal hemianopia, right, where you don't see on the lateral sides from the eyes because the pituitary is pushing down on your optic tracts, the optic cross, right? Remember the pituitary is right above that, and you'll lose your lateral vision in patients with adrenalectomies. So watch out for that. And here's a little bit of a revision that I was looking at before just for your interest. This is kind of how our adrenal hormones are produced and which levels they are at. So we have our aldosterone in the glomerulosa, our cortisol in the fasciculata, and our sex hormone sex stromal hormones in our reticularis. So here's a little bit of a review, and remember ACTH causes cholesterol to be put into the mitochondria more and more to increase hormone production. That's how it acts. Just a little review on that for you, and a little PTSD from early medical school. Alright, so I hope this video helped. Look out for the next video on low cortisol states, low adrenal states. That question will be coming soon. Hope this video helped, and I'll see you on the next one.